Good afternoon and welcome to another Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, and streaming on Facebook Live. We appreciate you joining us for this program this week. Let me start by saying first thank you to Dr. Jetmore for sitting in for me a couple of weeks ago, and also to Jason Troutwine, who I think could be the new me in this chair. I thought Jason did an excellent job last week. And
Jason did great, but you know, there's really no quite replacing you, Eric.
I keep trying to back out and give myself an extra hour a week, and you all just
try
kind
to
of
preempt
keep
that a little bit,
pulling me back in. But I appreciate Jason sitting in. I really do. I appreciate it. The numbers just continue to climb. So we're going to start as we normally do with what happened during this past week. Dr. Jetmore, we will start with you.
Well, it's a situation where last week things were bad, and they increasingly continue to get worse. Let me give you a few numbers. Our positive cases going back to Sunday, we had 41, then Monday 38, Tuesday 45, Wednesday 74, Thursday 87. Back in the spring, these daily cases would be 3, 4, or 5. They were single-digit cases. We had 259 positive cases last week. This week we have 285 after just 5 days. We've had 3 more deaths this week. All were over their 70s. They were all men. One was in a long-term care home. Overall, we've had 36 deaths since this pandemic started, but 21 in the month of October. Our 7-day positivity rate is around 9%. This is up 1 percentage point since last week. Our unique positivity rate, these are individuals who've not been tested before, is 19%. At our Elder Bierman site, we're continuing to test from Monday through Friday. That's at 601 East Main from 8 a.m. till 6 p.m. We're testing over 200 people a day. And if you do want to come down there and get tested, you're welcome. We have so many people down there now that it would really help us if you would schedule online at scheduling.coronavirus.n.gov. We can do up to 50 rapid tests a day, but people need to meet certain criteria in order to have this rapid test from the health department. And one of them is you must be asymptomatic, or you must be symptomatic, I apologize. You must have symptoms. Anyone obviously can still get the PCR test. Our Optum site over in Cambridge is testing around 50 people daily. They're open from 8 a.m. to 8 p.m. At 138 West Main Street in Cambridge, and they're going to be there at least through December. We were kind of keeping them there month by month, but this is good to know that they'll be in there through the end of the year. We've got 2 schools that have closed for 2 weeks, Nettle Creek School and Northeastern. They're grades 6 through 12. Richmond currently has 121 students that are out of school, either because they have coronavirus or they're isolating because they've been contacts of people with coronavirus. And one of the things I want to say, as these numbers blossom, our case tracers are getting overwhelmed with work. So if you've been a close contact with somebody that's obviously has COVID or been proven to have COVID, go ahead and isolate yourself for the 14 days. Someone from the health department will contact you, but there may be a 2 or 3 day lag, and you should isolate during that period. Our police department, our highway department, our fire department, 2 dental practices have been affected with COVID. So it's vital that we avoid gatherings. We've seen clusters in churches, weddings, funerals, businesses, and agencies. One of the things that's coming up is Halloween. So it's important, this again is another gathering. So stay home if you're sick or if you're a close contact. Don't go to these large events. I know there are a lot of businesses that are wanting to have Halloween gatherings. This could be problematic because the mayor and the commissioner have made a mandate that we can't gather more than 75 people. And we're hoping that there'll be some enforcement of this from the city. The hospital is at a point where they have enough COVID-19 patients that they're going to be forced to limit other services they do for the community in order to deal with this COVID population. So things are not happy this week, Eric. I want to end by saying it's important that we mask up, socially distance, wash our hands, and avoid gatherings.
You can tell I'm a little rusty at this. I didn't introduce the doctors. Dr. David Jetmore, Wayne County Health Officer, Dr. Thomas Huth, Vice President of Medical Affairs for Reed Health. He was a perfect lead-in to you, Doctor.
Now I'm very depressed. Thank you, Dr. Jetmore. No, I'm obviously very familiar with all these statistics, and we don't like to hear them. And we'll be getting to looking at graphs a little bit later on all of this. And Dr. Jetmore mentioned that this is beginning to impact operations at the hospital, and that's absolutely the case. We are running generally in our med-surg wards around 95% of capacity, which is very high to be doing on a regular basis. We've actually had a couple days this week where our ICU was completely full, couldn't accept any other ICU patients. Thankfully, we've been able to move several people out and have a little capacity there now. We have, because of the number of known positive COVID patients or suspected patients who need to be in our containment areas, we've actually expanded the containment areas as much as we can on the regular floors, and we've cobbled a couple of additional patient care areas that we normally would use for infusion patients and cancer patients. We've temporarily moved them to larger conference space with temporary bedding for the regular services, and we're using their established areas for COVID patients right now, so those are full. And it really is to the point that in order to handle higher levels of COVID-19 related patients, we'll have to cut back on other services, and that's a painful decision to make. You know, you can only fit so many things in the box before you have to remove something else to make room for the other thing. And I don't know right now what the order priorities of cutting services will be, but that is being worked on, a revision of the plan on that, and we're trying to avoid that at all costs, but we're really close to that point.
Visitors into your facility, obviously in the spring, things were shut down. Talk about what your visitor policy is at this moment, so folks know that. Obviously, if you're a COVID patient, you're not having visitors at all, but for people who have had other surgeries and things, what's it like there for them?
Well, we have had to make a change that was put into place this week to kind of roll back a little bit to what we had earlier in the pandemic, where we had to really severely limit visitors into the buildings at all. We continue to do the checking at the doors and requiring anybody who comes in to wear a mask. But now, if you're going to visit a patient who's in the in the hospital, then there can only be one visitor per patient per day. You know, what we were running into was that, through kind of allowing things to roll back more towards what you would consider to be normal visitation, what we're running into was situations where people would bring a whole carload and maybe they'd kind of file upstairs one after the other. And I totally understand that. You know, people have close families, and we worry about people who are in the hospital, and we want to visit with them and give them comfort and so forth, and we totally get that. And we want to enable as much of that as we possibly can. But just having lots of people coming into the building is a risk, because there's so much in the community now. We're detecting, I think the number was through yesterday, total of 283 positive. By the way, I keep the statistic through yesterday for this week. And when you think about how we're probably only detecting a tenth or less of the total active cases that are out there, total new cases, that means there are theoretically many hundreds of people who are actually positive and capable of spreading the virus, either don't know it or they have minimal symptoms, don't really, there's just no way of knowing who those people are. And to have people coming in off the street, wandering in the building, up into the patient care areas to potentially expose staff, expose the individuals who are there for other services, we just can't really take that chance. And so we're really clamping down, and we're asking people to register with a temporary guard station at the base of the elevators to get basically a pass to go up. But once, if somebody does that and then they leave, they cannot come back. And once somebody has visited one patient that day, that's all that patient can have that day. So families have to be really selective about who's going to come in and how long they're going to stay and that kind of thing. We will have it. We have exceptions for certain situations like end of life and so forth. People in the hospice area, we were handling a little bit differently, but those are being handled on a one-by-one basis to create the exceptions. So I think everybody needs to know that when they're coming, they need to sort of plan, who's going to visit grandma today and be deliberate about that choice and help us keep everybody safe by not trying to circumvent the process. We're not having hall monitors checking everybody's pass or anything, so there's a certain amount of honor system that's a part of this. But we need everybody's cooperation to make sure that everybody remains safe.
You're watching Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, streaming on Facebook Live. Before we get to questions, and I know we didn't get to a lot of them last week, so we want to try to get to those kind of early. There's always this conversation that's kind of out in the public about whether COVID is as deadly as people say. Can you two speak to whether there is actually a clinical differentiation between passing from COVID or passing with COVID?
Well, there's a certain judgment call that goes in that. You have to realize that when a doctor fills out a death certificate, which those of us who are involved in clinical practice do to one regular extent or another, depending on what that practice is. I do it fairly frequently because of the clinical work that I do with the aged and chronically ill. There's a judgment call about that you have to apply what's the cause of death, but you also have to realize that there isn't necessarily, it's one thing for somebody to have a heart attack and fall over dead, but typically in a hospital setting, as an example, somebody may become ill with pneumonia, but then they get a cascade of other problems. And so the death is the result of maybe the kidney failure, the heart failure, the other things that came along with it. And so what did they die of? Did they die of the pneumonia, or did they die of the heart failure? Well, the reality is they kind of did both. And so you have basically a hierarchical ordering of the contributing causes, starting with the thing that was most responsible or most immediately responsible. And then there's also a place on the death certificate where you can add in other more peripheral contributing factors of underlying conditions and so forth that may have also been present. So it isn't a hard and fast, yes, no thing. But with COVID-19, there are a couple of different ways that people can die from it. One is you can die from the acute viral illness. Another is you can die from there's a phase of illness that happens in many people of a kind of an unregulated immune response that causes damage that's not regulated and balanced. That's often referred to as the cytokine storm from the breakdown products of cellular contents as that process proceeds. That's a separate issue from infection, but it is triggered by the COVID-19. And both those things you would say pretty clearly, if that's your situation, you died of COVID-19. But if you have a patient who has active COVID-19, but they also have chronic medical problems like heart failure, kidney disease, and so forth, and they have an abrupt deterioration of those conditions and die with all of that, then the doctor has to make a clinical judgment about what was the direct contributor or not. And if in that situation, if COVID-19 was likely a triggering event, it's going to get on the list, and it will be counted as a COVID-19 death in that case. Now, there is a designation you can make that, if clearly someone just, had COVID-19, but they truly died of something else. The classic example of that is somebody dies in a car accident, either they were known to have COVID-19 or for some reason the body was tested and it was positive, and that has happened. Well, then we would say that's clearly a case where somebody died with COVID-19 but not of it. But making those distinctions isn't always so straightforward, and so it requires judgment be applied, and that's what we doctors do on an everyday basis when it comes to certifying death. It can be tricky and complicated to figure out exactly what the sort of the final pathway was and what were the contributors to that.
Many people will die in the hospital from a cascade of events like you alluded to. One of the things that this brings to mind is this has kind of become almost a political question as well as a medical question, because I think there's some people that are saying the epidemic is not as severe as you doctors are saying, and that these people are being overcounted. People on the other side argue that actually the deaths are being undercounted. But the one thing that you can't argue with is there's a predictable annual mortality in the United States. And we are 200,000 plus people over that predicted mortality. And those numbers cannot be argued with. Now, something caused all these extra people to die this year. I'm guessing it's COVID-19. But the patients that I had during my clinical practice that succumbed to their disease were almost all head and neck cancer patients. But even then, there were a cascade of events that they might have died of a pulmonary embolus after surgery. They might have died of overwhelming infection that they couldn't deal with because of the head and neck cancer that had debilitated them. So I agree, Tom, it's often difficult sitting down with that death certificate and writing down what actually caused this patient's demise. But there's no doubt that coronavirus has dealt us a devastating blow in terms of the mortality this year.
And I would add to it, the situations I'm familiar with, we have a number of poor, patients who die at Reed. They're not all from Wayne County. They may be from other places. It's pretty clear, that nobody has to make anything up or really has to kind of sort of peer into it. The patients who die with COVID-19 as opposed to of COVID-19 are actually pretty rare, in my experience, looking at the different deaths as we analyze them and talk to people who are involved with the care of those patients. They'll frequently have a cascade of problems, but it's clear that COVID-19 was the trigger in really virtually all those cases. In our experience, that's the case. So, but I think there's an aspect to the question, Eric, that really kind of goes back to understanding that we almost have a different disease state depending on what's the circumstances of the person who's infected. Probably the biggest differentiator in all of that is age, but also the typical comorbidities, high body mass index over 30, presence of diabetes, heart failure, other types of chronic lung conditions. Those are all risk factors, and when people have those risk factors, they have a much higher death rate, and we're talking the order of magnitude of from, a 10-year-old probably has a risk of death of 0.02% compared to a 90-year-old has a risk of 25% or higher. That's a number of orders of magnitude difference. And so it's a very different disease when it's in a child or a young person compared to when it is with a very old person, particularly when they have chronic comorbidities. And I think that's what makes it hard for those of us who are in the younger age groups to kind of relate, because we don't see it as such a big deal. I don't, Sally Joe next door had it. She stayed home and watched soap operas all day, but seemed to be perfectly fine. But grandma, should she get it, could be in dire straits, and that duality, it's either sort of not a big deal or it's a tremendously big deal. I had this conversation with a colleague of ours who does some work in nursing homes and in fact is taking care of a number of patients at a nursing home here locally a month or so ago where they had a big outbreak. And he said to me, it's weird. I said, how is it taking care of people in the nursing home? I said, well, in the nursing home, a lot of them, either they have few or no symptoms and it's not that hard to take care of them, or they die. It's sort of one or the other. And so I think we have to realize this is the nature of this disease. It's very different from most others we encounter. And I think that the big problem for younger folks is to understand that, yes, if I'm 20 years old or 30 years old, the risk to me may not be so high. It's not zero, however, but it may not be so high. But that doesn't mean I can just have a laissez-faire attitude about it, because I can, because of the asymptomatic transmission we know is very common, I can be a conduit to somebody who would be at a high risk. And I think if we went around with more of a sense of social responsibility, that I'm kind of responsible for what I pass on to others to a certain extent, morally responsible for that, more people would take care to not, that they don't become a part of that conduit to the people who can afford to contract it least.
Just as a historical digression here, as you point out, Tom, this is most fatal to the older age group. The older you get, the more likely you are to die. In the 1918 flu epidemic, there were two peaks, one for 20-year-olds, that decade, 20 through 30, and another one for the people in their 50s. Well, society back then had a totally different attitude toward dealing with the pandemic than they do now. And I'm sure it's because of who was affected.
Yeah, and I think we had a version of that with H1N1. Actually, I'm glad you brought that up, because if you think back to H1N1 in 2009-10, there was a lot of impact, very sick people and deaths in the 20 to 30 age range, and not so much in the oldest age ranges. And there was a lot of conjecture about why that might be, but I think then it actually got more attention because it was much more serious for the younger aged folks than this is. So we have a very different disease process, and we all have to recognize that and act accordingly.
Dr. Thomas Huth, Reed Health, Dr. David Jetmore, Wayne County Health Department. They're here to answer your questions. You mentioned Halloween coming up. We've got 3 questions that we're going to go with in succession that all came in about Halloween. So we'll bring all of those questions up and then we'll let you deal with those. So let's start. With the increase in cases and positivity, should local communities take action in regards to trick or treat hours? Should I be concerned about my children going trick-or-treating tomorrow or passing out treats myself? And are we anticipating any type of setback or spikes in positivity cases from this weekend's holiday activities? There's one more, and we'll bring these back up as you all are talking to kind of remind you as we go through them.
Good. This is a lot to digest.
But I think your answers are probably going to encompass a lot of this. How will the recent decisions by the local government officials and health advisors impact community trick or treating? What are best practices? So
let's have the first one over again.
Okay, so let's go back to the first one. With the increase in cases and positivity, should local communities take action in regards to trick or treat hours?
Well, I think the short answer is yes, they should. And Christine and I, Christine Stinson, the executive director of the Wayne County Health Department, met with Mayor Snow and Commissioner Paus regarding this. The Parks Department had intended to have a large gathering in the park for Halloween, as they have had in the past. I think in the past it was indoors, but the positivity rate is so high now, 9%, that we felt it was unwise for this event to take place. More recently, with the hospital starting to be overwhelmed with COVID-19 patients, we recommended that the city consider canceling trick-or-treating altogether. Really, the safest way to trick-or-treat is to not trick-or-treat. But the public officials felt that it was only 4 days away from Halloween. The kids had had a rough year. The event would be outdoors. They would be with their family, and suggested instead that we have Halloween, but issue guidelines to make it safer. And those guidelines are everyone should wear a mask, including the mask of Tony the Tiger or whoever they're going at, Peter Pan, that the people who are handing out the candy put the candy at the end of their porch and with a sign inviting the kids to take a treat. People who have all the comorbidities of their health that Dr. Huth recently enumerated, they should probably not participate at all. Just turn off your porch light, take a bye on this Halloween, and we'll be back next year. The hours are limited. I think they're from 5 to 7, which I think is pretty reasonable. But I have to say, in order to have, there's no human activity that does not have risk, and trick-or-treating is one of them. And you know, the safest way to trick-or-treat is, unfortunately, not to trick-or-treat. What was number 2, Ryan? Should I be concerned about my children going trick-or-treating tomorrow or passing out treats myself?
Again, you've kind of touched on that.
Well, I think I touched on number 1. I didn't on number 2. And you can, I don't mean to hog this, Dr. Huth. I'm sure you have thoughts about this as well. I think we will see spikes from this holiday, which will appear in about 2 weeks. I was looking back on some of the numbers that you've given us, Tom, on the increase 2 weeks after the 4th of July. We all gathered for the 4th of July, and 2 weeks later, the positive cases were 3 times what they were on July the 4th. I think 2 weeks from Halloween, we'll see a spike in cases. A lot of these will be from area businesses that are asking people to come for Halloween get-togethers in bars and restaurants and other businesses. This is really problematic because you have people that are gathering. They will probably be inside. Many of them will not wear masks or social distance. And hopefully these crowds will be less than 75. They've been mandated to be that number or less. But again, it's very hard to police a crowd, Eric.
Well, yeah, I mean, gosh. And by the way, you're showing your age. Tony the Tiger. Do kids these days know who Tony the Tiger is?
They probably
I think he's making a comeback.
So, that'll be a costume that'll be readily available to these young tykes.
Yeah,
if
I
they
mean,
wanna...
so, the future's not written. We don't have to have a spike in 2 weeks. If people will do the right thing tomorrow.
You're right. The future is not written. It's
And,
just predicted.
So, but unfortunately, our fears are what they are. I think there's two aspects about risks involving children to maybe keep in mind for young parents to keep in mind. One is the personal risk to the child. What's the risk that my child might get, actually significantly sick, or have one of these rare but not impossible sequelae of the multisystem inflammatory syndrome of children, or have one of the prolonged syndromes that can happen with myocarditis and some things like that. Those are risks. They're not tremendously high risks. The overwhelming likelihood is that a child who contracts COVID-19, a normal, healthy child, is not going to be very sick and would recover quickly. That has been the case pretty much around here. Having said that, there are some situations where children can be at particular risk. And I would note that there's a version of this in adults, but in children particularly, the highest risk is actually with Black and Latino children. Also children who have high BMI, body mass index. And then of course children with underlying chronic health conditions. So, I don't think any parent should just dismiss out of hand the possibility that their child could get seriously sick or have sequelae. That can happen. But that's one aspect of risk, however unlikely it might be in an individual child's case. The other aspect of risk is, could my child, who is not responsible, can't understand all this necessarily, the younger children, they're not supposed to, we don't expect them to kind of get it about viruses and how they're transmitted. But as a parent, I need to be thinking about, could I unwittingly allow my child to become unwittingly a conduit for passing this virus on to somebody who really shouldn't be in contact with it? Do I have elderly neighbors? Do I have elderly family members? Are there other people in our lives who are at risk? That's where we need to take the responsibility. So, the CDC has some guidelines out there, some suggestions, recommendations about how to do Halloween trick-or-treating if you're bound to do it, that you're going to do it. And that's, don't go around with groups of children. Keep your family unit in its own bubble. Don't get bunched up. You mentioned wearing a cloth mask or even a paper surgical type mask underneath a costume mask. The costume mask is not sufficient. And
I think the Tony the Tiger mask gives a lot of protection, Tom.
You're now causing a run on Tony the Tiger costumes. But I think also for people who want to hand out the treats, I like to do that. We're not going to this year. We're going to turn off our light, and I just don't feel like it's a risk worth taking. But if you're determined you're going to do that, I think the best way to do it is set up a card table at the end of your driveway or front sidewalk and lay out treats that you have placed wearing gloves. Lay out treats in a row that kids can just walk by and pick them up. And so to avoid people coming up to the door and bunching up at the front door. So I think those are some of the things. The CDC guidance is very easily researched on the internet. You just put into Google CDC Halloween guidelines or something like that, and you'll go right to their page with more suggestions if you're bound to do it. I personally will not be this year in any form. I think it's probably best not to under the circumstances. Next year will be next year, and I think we'll be hopefully in a much better place then.
And we're going to bring back up question 3 in a minute, but just for those folks who weren't with us a few weeks ago, we actually had Denise Retz on the show. She had worked with the health department in trying to put together guidelines so that they could have a safe event. So I don't want people out there thinking that you all are just trying to shut down Halloween. You all worked with them so that things could be safe and that Halloween and trick-or-treating could be happening.
That's exactly right. A lot of thought has gone into this, a lot of agonizing, because we realize that every decision we make, every recommendation we give has repercussions, both good and bad, expected and often unexpected. So I'm glad you brought that up, Eric.
Let's bring up the last question. Let's make sure we touched on all of the questions again. How will the recent decisions by the local government officials and health advisors impact community trick-or-treating? I think we got that. And what are best practices? I think we got that. So we can move on. I just wanted to make sure that we kind of touched on all of those questions. So we can bring those down. I'll remind you that you're watching Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, streaming on Facebook Live. We are taking your questions. You can put those on WCTV's Facebook page, or you can also send a tweet to @WCTV Info. Let's go to the next question. Last week it was mentioned that schools were not the sources of spread, but several schools have gone virtual now. Are we having students or staff test positive?
Yes. This is kind of a two-part question. The schools there doesn't seem to be a lot of spread within the school. I know of one exception of this where we had 2 students in the same classroom that may have passed the virus back and forth. But most of the cases in the school have come in from outside the school, gatherings outside the school. The schools have done, in my opinion, a fantastic job given the tasks we've given them. It's difficult to educate our children in times when there's not coronavirus epidemic, and they've shouldered this burden without complaint and done an incredible job. But the answer to the question is there's not been a lot of intra-school spread. It's all come in from the outside. And those schools have gone to virtual because they've had most of the patients, or most of the students rather, have had to miss school because they've been close contacts, not because they have COVID.
There's a follow-up to this, I'm being told, so let's bring that up. Any idea how many students are testing?
I can't give you that number. I can tell you the number of students that are out. Like in the Richmond schools, there's 140 students out. Christine, if she were here, might be able to answer that question, but I can't.
Christine, if you're watching, if you jump on our Facebook page and can answer that question, that would be great.
I think she's down at the testing site this afternoon. I talked to her this morning.
Being busy. Okay. Next question up. Through contact tracing, have we seen any outbreaks in church congregations? Why are houses of worship exempt from the current orange guidelines?
I think they're exempt for political reasons. We have the right to gather and worship in the Constitution. From a purely epidemiologic reason, they should not be exempt. I mean, obviously the virus spreads in any group gathering. It doesn't care what the reason is for the gathering. But that's why I think churches have been exempted. And yes, there have been outbreaks in church congregations. Many of these congregations meet without masking, and there's a lot of singing, which spreads a lot of the virus. I hasten to say that many church groups meet virtually, and many of them, when they do meet, carefully distance and wear masks. So it depends on the behavior of the various church groups.
Yeah, I want to kind of echo in on that. We have First Amendment right to freedom of religion, and I think that's always been the stance of in Ohio. I've noticed the governor of Ohio has always taken the position that we don't want to shut down houses of worship, and that was more explicitly said most recently by the Indiana governor a couple of weeks ago, I noticed. But I think, it's kind of like anything else. If you do it right, you can do it. I mean, the church I go to is very, very good. I feel very comfortable going there. But they've got parts of the pews marked off, don't sit here. They kind of assign the seating so they know who was sitting where. Mm-hmm. Everybody, you have to wear a mask inside the building. We don't have hymnals in the pews now. They're projecting the lyrics, and they're asking people not to sing loud but to sing softly, and they're doing that with masks on, and things like that. So I think you can do it well and not have a problem. But in my understanding, where there have been some problems in churches is where they have kind of ignored some of the standard guidelines. And so it's really not the fact of having church services, it's the way that they're done.
I recently, 2 weeks ago, went to Indianapolis as the sponsor for my grandson Sam's confirmation at the cathedral there in Indianapolis. And we were in this huge church. We were all spaced out, probably 10 feet apart, in groups of twos, sponsor and student. No one else could come except the parents who were outside. The bishop's there wearing a face mask. We all wore face masks. So you're exactly right, Tom. You can do these things. A lot of times it comes down to space. Do you have enough physical space inside to obey these 6-foot guidelines?
We've got probably about 17 minutes left in the show. We're going to try to get 2 more questions in, and then we're going to go officially to this week's number. So what's up next? How risky is it for me to see the dentist? I'm 79 and in good health, but my husband is high risk. I'm interested to hear Dr. Jetmore's position, but I've been to the dentist once or twice during the COVID, and I've heard of other people's visits to their dentist. I feel like the dentists are doing a really good job. The risk to the patient going to the dentist is really, to me, is not a significant concern there, because I see the dental practices taking extreme precautions. It's probably more the other way. I have to take my mask off in order to have my dental work done. That makes me more of a risk to them. But they're taking precautions for themselves. They're wearing eye protection there, as well as and mine wears an N95 mask with a cloth mask over. The hygienist and the dentist does, and then they're all the time gloving and sanitizing and so forth. So, and plus I noticed that many of them are taking extra steps to avoid to improve their ventilation systems, so that if there's any aerosols generated, they are carried away in a safe manner. So I feel like the dentists are doing a good job. I don't think anybody should be particularly worried about their own safety going to the dentist. That's my personal opinion. I think our dental care is an important part of our overall health care, and you should go to the dentist, especially if you definitely need something done, or even if you're just overdue for a routine cleaning and examination. I don't feel that anybody needs to have a particular concern about that. If you do have a concern, call the dentist and ask them what steps are they taking to provide a safe environment for everybody, and I'm sure they'll be happy to explain.
Yeah, I had a similar experience. I went to the dentist to get my teeth cleaned, and they took my temperature. I filled out a questionnaire. They made sure I wasn't sick. We did have some COVID in a dentist's office, but it was not from a patient or from it wasn't spread between patient and practitioner. It's like you talk about being at the nursing home, Dr. Huth. It's what you do after work that affects whether or not you're having COVID. Usually when you're at work and not at home or at break, where you might let your guard down, that this can become problematic. But I agree. I think dental health is an important part of your health, and we need to maintain our teeth and keep them clean. I would not be wary of going to the dentist.
Next up, let's get one more and then we'll go to numbers. Do we know why COVID-19 patients lose their taste and smell? How long does it typically take to get back?
In my understanding, well, first of all, I'm not sure anybody knows precisely why it happens. It's assumed to be essentially a neurological manifestation of the immune system overactivation is maybe the simplest way to explain it. But I don't think anybody really knows for sure. Maybe Dave knows a little bit more differently. Since that is your field, ENT, basically, and you probably could comment on it. But maybe you're more interested in that. But as far as how long that lasts, it might just be a few days or it might be a couple of weeks, but it also can be a prolonged thing. There's a famous case of an NBA player who, to my knowledge, he had COVID-19 like in April or May, and to my knowledge has not yet recovered his sense of smell.
I think the worst possibility is that you may never recover your sense of smell. And basically, we always talk about smell and taste. 90% of what we call taste really is smell. There are supportive cells of the nerve, the olfactory nerve. Your olfactory nerve is right here at the very top of your nose, and it's the only nerve in the body that's exposed to the atmosphere. So it would be particularly vulnerable to respiratory virus. Those supportive cells are affected by the virus. They're damaged, and they can't support the nerve. The nerve dies back, your sense of smell is lost. I think a lot of it depends, Dr. Huth, on how severe the injury was. I think if you have enough of an injury, enough of a viral load, when you get this viral load, you may never get it back again. Other than that, I think it'll return in degrees. We would see, I personally would see 4 or 5 cases every winter after the flu season. And these people, it wasn't supportive cells, it was the nerve itself. And those people rarely, if ever, recovered. It was a lifelong thing. But again, it was a different type of injury. So I'm hopeful that most of the people who suffer this will get their sense of smell and secondarily their taste back.
You're watching Ask the Doctors on WGTV Channel 11, WCTV Channel 21, streaming on Facebook Live. We have a few more minutes for your questions, but we're going to stop as we do every week and let Dr. Huth go through the numbers as they are, and they are not good.
Right. Ryan will bring those up here momentarily, I'm sure. But I construct these graphs just based on the spreadsheet that Christine's staff sends me periodically, and just so we're all straight, the numbers here might vary a little bit with numbers you'll find in other places, and part of that is the way that I count them. First of all, I'm only counting the laboratory positives, and I count from the week is Sunday through Saturday. That might sound like a strange week to count, but that's the way that the epidemiology authorities count the weeks for the purposes of, say, the flu season and so forth. And so to make it consistent with the flu season, I've just chosen to count it that way. But what we have is the last bar on the right is gray because it's not a complete week yet. That's the so far this week through yesterday, 283 known positives. That's from last Sunday to yesterday. And already we're above what we had the entire week before. And on this track, we're on track to be above 300 for the week. Hopefully that won't happen, but that's where we're at. And those are cases in Wayne County. The second slide gives, which I hope is becoming more familiar, the age grouping breakdown. And we still have a kind of an over-representation, you might say, or an increase in representation in the oldest age groups, the 70 to 79 and 80 plus, so to where they are, at this point, 21% of the cases so far in October, and that's on about 903 total cases. 21% are these folks, And that's particularly bothersome because they're the ones at highest risk. I didn't bring that graph today, but in the 70 to 79 age group, the latest case fatality statistics is about 10% mortality rate, and in the 80 plus, it's about 23%. So when you sit down and do the math on that, what should we expect in terms of the cases in those age groups that we've seen so far this month? And that's the next one, Ryan. That's the black bar on the right. Just on what we've seen so far, we should expect to have 29 deaths this month. And as a reminder, going into this month, we only had about 16 or so prior to October, and we have had 21 so far. So we're well on the way to making that 29, unfortunately. And I have to remind myself and remind other people, I'm just giving you the data as it is, what this suggests we're likely to see to try to make it real to people. I'm not predicting 29 deaths. This isn't a personal thing. I will not be offended if we don't have 29 deaths. This is not about me being right. I would like to be wrong because this is a very unfortunate thing.
And Dr. Huth, how did you arrive at that figure? You just multiplied 25% by the number of 70 plus people that had COVID?
Basically,
Right.
yes, taking the numbers in those age groups times their mortality, case fatality rate for their age group, that's what you come up with is 29 total out of those two age groups. It's just a simple mathematical exercise, but I think that's why it's worth doing, because we have to somehow make this real to people that we're responsible for these things happening. In a sense, they're preventable if everybody else, particularly the younger folks most of the older folks I know are doing what they can. They're staying out of situations. They're being very careful because they understand best their risk, but it's the younger folks who can transmit to them must realize that this is the result of that. We can deflect that down, if we do great this weekend and everybody resolves to get back on track, we can do better. But I'm going to continue to calculate it this way, and I don't want to be right. I want to be wrong. I want my numbers to be way too high. That would be great from my perspective, but we'll have to see what happens.
Well, it's the 30th of October.
Mm-hmm.
We've had 21 deaths. So
Right.
according to your graph, 8 people will die tomorrow.
Well, no, that's a good point of differentiation. That is, the people who got sick in October
Okay.
are at risk of dying.
All right.
So
Good
I plan
point.
to actually aggregate this with the November numbers to kind of continue on, because I'm actually accumulating this data on a 2-month basis.
Okay. And your average health reads health average daily hospital
Correct.
volumes.
That's the last slide in there, and we can see in the last set of bars, we have, on average this week, about 57 patients in the containment areas. 29 a day are known positives on average. The one bright spot is we're not having so many ventilator patients. So there's a sense in which I feel like, compared to earlier in the epidemic, this is has evolved into somewhat of a milder disease, but it's still very dangerous.
And yet, the epidemiologists, when asked why are there fewer deaths and why, compared to the way things were back in April, they insist that there's no evidence that the virus has evolved either to be more virulent or less virulent. And they attribute most of this to the hospital care that the people are getting. We've gotten more sophisticated in treating this disease. We've had experience with it. What's alarming about your graph at 57 is this is one patient more than where we were on April the 11th, at the height of the epidemic in the spring.
Correct.
When the governor was basically shut down the state. So these are alarming numbers, Dr. Huth.
Yep, they are.
We've got about 3 minutes left to go, which lets you all know that the answer is going to have to be a little bit shorter, but we're going to see if we can get one more question in. What do you have to say to area physicians who don't observe the mask mandates and publicly state that masks are not effective in preventing COVID spread?
2 words, you're wrong. They are effective. I think they've been repeatedly shown to be effective. If you simply look, Eric, at graphs where people in a state make a mask mandate, the infections decrease. Then when the mandates are lifted, the infections go up. This is a clear correlation, and it's repeated over and over and over, is because we've had, every state's kind of marching to its own drummer. So we've had examples all over the United States, and we've seen this in other countries. So how someone could say that masks do not have any effect on a respiratory disease, an airborne disease, flies in the face of reason, in my opinion. What do you have to say, Dr. Youth?
I guess to kind of add on to that, I would say to such a physician, what evidence are you going by? I'm just curious to know. I mean, I think, way earlier in the epidemic, you and I might have fallen into that camp a little bit simply because at that point we didn't have much evidence one way or the other of the benefit. And even the national authorities were saying they were skeptical about the value of masks. But we've learned a lot more since then. And so we have to pay attention to that. Is it all completely definitive? Will there be more to learn about exactly what's the value of a mask and so forth? Yes, because this is a rapidly evolving situation. But I think it's pretty clear that the reality is what it is. Masks help, in addition to all the other safeguards. But if somebody has evidence and knowledge elsewise, they need to educate me because I think it's pretty clear.
Dr. Thomas Huth, Vice President of Medical Affairs at Reed Health. Also, still got your Wednesday night gig?
Yes, I do.
Hanging out with WHIL-TV 5 p.m. on Wednesday evenings, and also putting out some information on Twitter, I believe, through Reed Health. Is it not Twitter?
We are putting some things out on Twitter. Judy Shop is mostly handling that. I am doing LinkedIn and Facebook, and also have a magazine article coming out soon.
Okay, so if you're looking for information, he's making sure it's out there. Also, Dr. David Jetmore, Wayne County Health Officer, providing lots of information. And for those people, that person who continues asking, we have nothing to do with what comes out on the Facebook page of the Wayne County Health Department. It's not being handled in this show. That's not what this show is for. I want to remind you that COVID testing is available. You can do it in Cambridge City, 138 West Main Street. You can also get COVID testing done Monday through Friday, 8 a.m. to 6 p.m. at the old Elder Bierman site. So any of those locations are definitely possible. If you're going to be doing some trick-or-treating this weekend, definitely be careful. There are guidelines up from the Center for Disease Control. They have gone through that. You've heard what the doctors have said here. Obviously, you're going to follow your own advice. We just ask you to be safe. We will be back again next Friday afternoon at 2 p.m. for another Ask the Doctors on Whitewater Community Television's WGTV Channel 11. I hope you have a very safe weekend. Take care. As always, I wish you well.